there's been so much going on in terms of new information about the long-term benefits of the immune checkpoint antibodies, with ipilimumab, of course, being the agent for which we've got up to 15-year data now. The PD-1 antibodies, of course, have now come to the fore, and even with head-to-head data showing superiority to ipilimumab. So we're getting this rapid succession of data sets that really disrupt clinical practice, and then, of course, the combination. But let's hold the combination for a moment, Jeff, and if you could just sort of wind back the clock at least a few months before ipilimumab, nivolumab, or PD-1 CTLA-4 combination therapy was FDA approved. Where are we in terms of thinking through the impact of these therapies, patient selection factors, if any, that you think in terms of driving decision making and choice of therapy?
Well, the urban legend is that there's the proverbial tail on the curve for patients who get immunotherapy, either ipilimumab, nivolumab, pembrolizumab, and probably the PD-L1 antibodies like MEDI4736, which now has a new name, which I hate, or MPDL3288, which has another name that I don't like, so I'll use the old numbers. But in fact, it's a real phenomenon. Dirk Schoddendorf had just published some months ago in JCO an article giving some long-term follow-up in expanded access protocol patients who received ipilimumab. And if you get beyond 3 years in remission, partial, complete, or with stable disease, you're probably going to stay there for a long time. And again, I've been treating ipilimumab patients for 14 years, and I occasionally get an email or a letter or postcard from a patient I treated 13, 14 years ago when I was in Los Angeles, and they're alive and doing well. In fact, the person in whom I think it was probably 2001 or something that I saw my first case of colitis is a gent living in Dana Point, Southern California, still doing well. He sent me a postcard some months ago. So I think that it is clear you can induce long-term remissions with IPI because there we have the most experience. Yeah. I would venture a bet that nivolumab and pembrolizumab, two very similar anti-PD-1 drugs, will show the same exact phenomenon. With pembro, maybe we have a little less follow-up. With nivo, I think the data have been presented, and if you look at the long-term data, and I think it was presented by Steve Hody at ASCO this past year, for nivolumab from the original trial, it appears as if there is a plateau, perhaps in the 30 to 40% range. If you look back at the original AJCC data of, to be honest, ineffective therapy for stage 4 disease, that number would be maybe 10% on a good day. Right. With IPI, it goes to 20%. With nivolumab, it goes to 30 to 40%. Perhaps with the combination, it even goes higher at 3 to 5 years. But I think that there's a real phenomenon of a plateau. It looks preliminarily like you see the same thing with pembrolizumab, although I think the follow-up is maybe a little shorter. Yeah. But I think there's no question that the tail on the curve exists. And we're getting ahead of ourselves, but the other aspect of the urban legend is you don't see that with targeted therapy. And I think that Georgina Long has some data from the original trial that you were the first author on, that I was the last author on, of dabrafenib, trametinib, saying that's not exactly the case. Right. You can see a bit of a tail on the curve in long-term survivors with targeted therapy, but we all agree the best data, the longest-term follow-up, come from IPI, nivo, and pembro. And we'll soon be hearing, I suspect, from Mario Schnoll about some of the longer-term data from the original trial of IPI plus nivo, which also looks very promising.
Again, let's hold that for a moment. Thinking about the PD-1 antibody data, really with nivolumab and pembrolizumab, I think what's compelling as an immediate starter is higher response rate for sure. Immediate disease control that seems more impactful than ipilimumab.